and welcome to Fertility Talks. This is an initiative by Kiran IVF to spread awareness about infertility, the causes, the reasons for infertility and how to manage it and how to successfully overcome it. Today we are going to discuss a very important topic about fibroids. Uterine fibroids may be known by different names. Some people call it myoma, some people call it leiomyoma. But ultimately it's a condition which affects a lot of women, especially in the reproductive age group, and also when they get a little bit older, it can cause varying symptoms and might be difficult to manage. So today with our panel, we are going to discuss in detail about fibroids and what are they and are they dangerous, how to manage them, and especially related to infertility, why they are important. So as always on our panel, we have Dr. Kiran, Dr. Shravanti and Dr. Pratima. Glad to have all of you again. Thank you for joining us.
Thank you.
So Dr. Kiran, in your practice, you must have seen a lot of cases of fibroids over the years. So what are basically these fibroids?
Fibroids are nothing but a tumor, but the word tumor you should not actually get misguided by. It is called a tumor, but 99% of the times it is benign. It is not cancerous. Let me make that very clear right in the beginning of the talk. And these are, actually some muscle cells, smooth muscle cells of the uterus, which undergo an abnormal proliferation. And they form rounded tumors or elongated tumors, which consist of muscle and fibrous tissue, basically. So in colloquial languages, they are known by different names. And they are quite common. By 20 to 50% of the women will have it in their childbearing age.
Thank you for that. So Dr. Shravanti, in your experience, what percentage of women get affected by fibroids?
Yes. Actually, fibroids, as Dr. Kiran said, these are benign tumors of the uterus occurring most commonly in the women of childbearing age. They rarely occur before menarche and they regress after menopause. So it is basically a tumor that occurs in the women of childbearing age. Usually around 20 to 50% of women of childbearing age are having fibroids, and the lifetime incidence of fibroids in them is approximately 70 to 75%. And coming to the fibroid incidence with respect to symptoms, usually most of the cases, about 75% of the cases are asymptomatic and only 25% will have symptoms like heavy menstrual bleeding and pain abdomen, pelvic discomfort, like that.
Right. So basically you're saying that they may go undiagnosed.
Yes.
So Dr. Pratima, we know that fibroids may cause some serious health concerns, but are they actually cancerous?
Thank you, Dr. Samit, for the question. Fibroids that occur in the uterus in the reproductive age group women, 99% of these fibroids, we call them tumors, but are non-malignant. They are non-cancerous. So it's very important that you counsel the patient that you have a tumor, but it's a benign tumor. But it's always important in the later half of the reproductive age group, that is beyond 40, to always have these kind of tissues where the histopathology is done, and then you can completely assess and evaluate about the fibroid that it's non-cancerous. But in the earlier halves, 99% of these leiomyomas or fibroids are non-cancerous. Fibroids, 99% of the fibroids are non-cancerous, that is, they are non-malignant. But it's always better to get a histopathology post-myomectomy to confirm the diagnosis.
So Dr. Kiran, what is the causative factors for these fibroids? What are the reasons that these fibroids occur?
Many times the cause may be unknown, but what causes the predilection for having these fibroids? A few factors which I will enumerate for you. One is that they are estrogen dependent. So whenever estrogens are more in the female, they are more likely to get fibroids, like in the younger age or when they are kept on estrogen therapy. Second is also, they say that it may be a familial factor also, hereditary. In some women, if their mother and aunts and others had fibroids, then they too have fibroids, and it can be transmitted in what way, we are not very sure about that. Racial factors also come into picture, where certain races, brown skin races or African races, they are more predisposed to having this condition of fibroids in their uterus.
So Dr. Pratima, what are the risk factors for fibroid?
As we all know that fibroids are common in reproductive age group women, but there are a few factors which predispose a woman to develop fibroids. One is prolonged infertility. Second is dietary intake of red meat or high fatty foods, blood pressure, and obesity. So all these are very important aspects in a woman's life which need to be controlled to take care of the fibroids.
So, Dr. Shravanti, do you feel that there is an increased incidence in some people based on their height and weight and where they come from, which race, which country?
Yes, there is racial disparity in the occurrence of fibroids. Black women are more likely to develop fibroids when compared to white women, and people or women who from sub-Saharan Africa are more likely to develop fibroids. The exact cause is not clear, but there may be a combination of biological and social factors, um, like their lifestyle, environment, and the age at onset of puberty. Usually, the puberty occur at a younger age in those women, and vitamin D deficiency also play a role, and family history of fibroids, and all these factors contribute to increased incidence of fibroids in African women when compared to the other races.
So, Dr. Kiran, these patients, when they're walking to your office, clinic, do they come with certain signs and symptoms?
To begin with, I would say that most of the fibroids may be asymptomatic unless they are in a crucial position inside the uterus. It also depends, the symptoms also depend on the number and the size of the fibroids. First time, maybe you diagnose it when she walks into your clinic for some other gynecological complaint, and incidentally we detect fibroids. That is one category. Now coming to the other categories with symptoms, I would say that predominantly we have to look for the menstrual symptoms. Menstrual symptoms may be a heavy bleeding, which is called as menorrhagia. The periods last for a long time and they're very heavy also. Sometimes they can have in between the periods also bleeding, and this bleeding can be painful, as I told you earlier. Now the other factors which may cause symptoms is when the fibroid grows bigger in size and presses on the bladder or the urinary tract, they will have urinary symptoms. If the fibroid is situated posteriorly in the woman's body, it presses on the rectum and anal canal, and it causes symptoms in the defecation, etc. So, depends on where the fibroid is and depends on how many number. And most of the times when they walk in for infertility also, we detect fibroids.
So, Dr. Patina, usually the management of fibroid is it very simple? Is it mostly daycare, or sometimes there can be emergencies which may be life-threatening?
In very rare circumstances, a fibroid can turn into an emergency treatment. The management of fibroid can turn into an emergency care management. This happens in women where there can be kind of a red degeneration of fibroid, where there's severe pain in abdomen, and this pain in abdomen is not managed by medical treatment or by symptomatic treatment. In these cases, she might require an emergency laparotomy. Most of the times, fibroids are managed under conservative or under laparoscopic procedures, wherein there is just daycare, involvement. The patient returns back to her residence by the evening or by the next day if it's a laparoscopic removal of the fibroid. So in very rare circumstances, the patient might require emergency. There is another condition where she might have, severe bleeding and turns anemic, or there are, that kind of situation where there is extreme blood loss. In that case is also an emergency hysterectomy. If she's finished her childbearing, she's in that area, in the zone where she's finished her childbearing, then hysterectomy is advised. Most of the times, it's symptomatic treatment only.
So, Dr. Shravanti, in your clinical practice, how do you diagnose fibroids? Are they easy to diagnose? Are they tough? How do you diagnose them?
As I said earlier, most of the fibroids are asymptomatic, and they are often found on routine pelvic examination when the woman comes for another complaint like white discharge or pain abdomen. And for the diagnosis of fibroids, we need certain investigations like pelvic ultrasound, which is the first line investigation for fibroids. Usually, we can know the number, site, and location of fibroids. Here in ultrasound, the fibroid looks like a whorl appearance with a capsule. But certain conditions like focal adenomyosis can mimic fibroids. In such cases, it is difficult with the ultrasound also to have a definite diagnosis of fibroids. In such cases, we can go for better imaging technology, that is MRI, which is magnetic resonance imaging, and it gives a better high intensity picture of the internal organs in the pelvis. So with the MRI, we can have an accurate mapping of the fibroids, that is the number, the site, and location of fibroids, particularly in relation to the endometrial cavity. So this is important especially when we are dealing with the patients of infertility, because when the fibroids are close enough to the endometrial cavity, then they will affect the fertility. And one more investigation we can offer is hysteroscopy. When we have a doubt of this submucous fibroid in the ultrasound, then we can go for hysteroscopy, which is nothing but visualization of interior of the uterine cavity, wherein we can see the submucous fibroid in the form of a polyp or any indentation of intramural fibroid when it is close to the cavity. So in such cases, it can be both diagnostic and therapeutic. We can remove the fibroid at the same setting itself.
So, Dr. Kiran, are there any international standards for classification, like certain international bodies must are classified about fibroids? What are those?
To have a uniform classification is very, very important because every obstetrician, gynecologist and infertility specialist should follow the classification so that there is no difference in the nomenclature. So what we do actually is there is a body called FIGO, which is for the whole world, Federation of International Obstetricians and Gynecologists, and they have put forth a classification. So main important what the patient should remember and also the clinician should remember is whenever the fibroid is located within the myometrial wall, that is the wall of the uterus, it may protrude. One thing is towards outside of the wall and become subserosal. And other thing is sometimes some fibroid actually starts protruding into the uterine cavity. So from the infertility point of view, then the one which comes inside the uterine cavity, that is classified as 0, 1 and 2 submucous fibroids, and the others which are within the uterine wall, the wall of the muscle, a little bit protruding, they are different classifications like 2, 3 and 4. So if somebody in every center follows this kind of classification, the other person also who is going through the notes or goes through the surgical operations, and when patient goes from one doctor to the other, we would perfectly understand what she had, what she underwent, and whether that kind of treatment was applied correctly for her. So that is very important to have a classification. From our point of view of the infertility doctors, it's very important to understand like whether this fibroid is just lying inside the muscle of the uterus and it's not going to interfere with the implantation. We can just ignore it, and if it's a small size. But what becomes very important for us is when this fibroid starts going towards the uterine inside the uterine cavity, and it actually forms like a mass inside the cavity, and it will interfere with the implantation of the baby, whether it occurs by a natural means or by test tube baby. So if this kind of polyp is hanging there in the uterine cavity or protruding and distorting the uterine cavity, making the endometrium unfavorable for implantation of the baby and the fetus, then we have to actually go in for removal of this fibroid. That is very, very important.
So, Dr. Shravanti, we know that certain fibroids can be managed medically with just medication and monitoring, and certain fibroids need surgical intervention. So, can you please elaborate in detail how to manage it medically when surgery is not an option?
Yes, fibroids usually most of the times are asymptomatic. So in such cases, watchful waiting or expectant management is the best option, wherein we can advise annual follow-up of the fibroids. Whether there is any increase in size or not, we can come to know with that. And coming to other symptomatic fibroids, we can manage with medical therapy like giving drugs like NSAIDs for pain abdomen and tranexamic acid and other agents to control the bleeding in case of heavy menstrual bleeding, and low dose OC pills also to control the heavy menstrual bleeding. All these will reduce the symptoms, but they do not shrink the fibroids. One more drug is there, that is GnRH agonists. These injections will shrink the fibroids by making the body to stop the hormones, estrogen and progesterone. So there is temporary menopause-like state. So the menstrual periods will stop in such patients. But these medical therapy is usually not advised for the women who are planning to have pregnancy, because these agents like low dose OC pills, progesterone ICDs, and GnRH agonists, all these prevent ovulation and prevent pregnancy. So medical therapy is not advised for the people who are planning to have pregnant.
So, Dr. Pratima, we now know how to medically manage a fibroid. Are there any other minimally invasive treatment modalities? And what are those? And can you please let us know about laparoscopic myomectomy as well?
With interventional radiology coming into management of fibroids, it's a drastic change in the management of fibroids via non-invasive procedures, where the patient doesn't have to go through the surgical cuts and incisions and goes back home the same day. The latest ones to treat fibroids are high intensity functional ultrasound therapy, which is MRI guided. Then there are radio frequency procedures, ablative procedures, again through the sound waves. You focus the fibroid through the MRI, and the sound waves are passed through these fibroids. And then because of this high energy sound waves, the fibroid cells are, there is kind of shrinkage in the size and vascularity of these fibroids. Another procedure, a little invasive, is uterine artery embolization, wherein you inject embolic agents via interventional radiology. A good radiologist could just pass on some embolic agents into the uterine artery, and thereby shrinking the blood flow to these, basically destroying the blood flow to these fibroids, and hence causing shrinkage of the fibroid. Then we come to a procedure called laparoscopic myomectomy. Now, this is indicated in women of infertile, who have been presenting with infertility, and again in the reproductive age group where you don't want to really have a big incision or a scar. You would ask them to undergo a laparoscopic myomectomy if you found fibroids which are in the intramural zone. Subserosal fibroids again do not really cause a great impact on her fertility. So if there are intramural fibroids, then laparoscopic myomectomy is advised, wherein you make smaller incisions and then you put the ports inside the abdominal cavity, and then the fibroid is dissected and removed by a surgical procedure. And this is also minimally invasive because it's not a big surgery involved, and the patient goes back home the same day.
Dr. Kiran, what is hysteroscopic myomectomy and in what scenarios is it useful?
Yeah, let me take the discussion towards my infertility point of view. General fibroids we have discussed enough, and we all know the different modalities of treatment. But what interests me as an IVF doctor and an IVF specialist is, where is the fibroid located, and is this fibroid in any way, even in the smallest possible way, going to interfere with the results of my patient? That is what I am interested in. So any fibroid which is situated in the cervical canal and is big enough where it will prevent my embryo transfer catheter to go inside properly, definitely I'll remove it, even if it is a small one also. Any fibroid now within the uterine cavity, if it's such a crucial place, that is the fundus of the uterus, the anterior wall or the posterior wall, and more than half of the fibroid is projecting inside the uterine cavity, distorting the cavity and then making my embryo transfer a failure, I would definitely go in hysteroscopically. That is, you go through the vagina, the cervix, pass a telescope that is called as a hysteroscope, which 40-50 times enlarges the view for me. I would go and remove the fibroid by the hysteroscopic ablation, or with the scissors the pedicle can be cut, and rest of the uterine cavity can be restored to the normal size and the normal whatever configuration it has. So that is my interest, and that is what I would do.
So, Dr. Shanti, we heard about laparoscopic and hysteroscopic myomectomy. Are there certain conditions when both of those are not possible, and then you have to look at other options like, say, an abdominal myomectomy?
Abdominal myomectomy is a traditional open surgical procedure wherein we cut open the abdomen through an incision given in the abdomen just above the pubic area. Here the uterus is visualized directly, and the fibroid is removed by delineating the capsule, and uterus is sutured thereafter with certain suture materials. So all this process will take time, and nowadays people are not going for this abdominal myomectomy because of certain drawbacks for this, and it is indicated only in certain conditions like multiple fibroids and very large fibroids not able to make out through laparoscopy, and very deep fibroids not approachable through laparoscopy. The main drawbacks with this abdominal myomectomy or any abdominal surgery is like delayed postoperative recovery. In case of laparoscopic myomectomy, it's a decay procedure, and the patient may be discharged by the evening. But in case of abdominal surgery, the patient has to stay for long, for about 2 to 3 days, and the recovery will be very less. And there is also chance of incisional hernias in abdominal surgeries. So all these drawbacks will make the patient to drive towards laparoscopic myomectomy.
Dr. Prathama, what is a hysterectomy and when it is indicated?
Hysterectomy is a surgical procedure wherein the uterus is removed. Indications for hysterectomy are when the woman has completed her childbearing period, she has severe symptoms related to fibroids, which includes excessive bleeding leading to anemia, severe dysmenorrhea and menorrhagia, which is painful periods, and prolonged menstruation. All these are indications for hysterectomy.
Dr. Kiran, we would like to have your concluding thoughts on views on this important topic.
To conclude, I would say, Dr. Samit, that because we face a lot of dilemmas when the patient with fibroid comes to our OPD for the infertility purpose. So here I am actually limiting myself to those kind of patients only. And a difficult decision is there on the clinician's part also, and you have to make the patient understand also that she needs this surgery very much, and she has really earned her surgery in the sense that it's very, very compulsory for her. So that kind of approach if you have, and you have different modalities at your disposal, like Dr. Shravanti said, ultrasound she very nicely delineated, but I would add little one more sentence, the 3D ultrasound and the 4D ultrasound, which we have available in our center, and the color Doppler study also. So this color Doppler will show us, how much is the vascularity of the tumor or the fibroid, and then how, it is interfering with the fertility potential. And 3D and 4D would give us a total, circumferential view of the fibroid. It will tell us that which corner of it or which part of it is growing into the uterus. So that makes our decision much easier and convincing the patient also better, in a better sense, that she also understands that this fibroid is interfering and I should get rid of it. Otherwise, like so many fibroids are there for infertility women. It's somewhere situated very close to the outer wall of the uterus, or it is within the wall but very small. So I would go by numbers. I would go by situation where it is situated. I will go by whether it is interfering with her fertility potential, and then I will decide what is the outcome to be, what is the procedure to adopt. One important point I would like to emphasize is that these fibroids may be very fast growing in some individuals, some patients, and she has had this kind of procedure where her myomectomy was done. Fibroids were removed 6 months to 1 year back only, but they regrow. So this also the patient should understand, and if she has come to us in that period where again it has regrown, it's interfering, we have to explain and redo the surgery.
Friends, that was all about fibroids and what they are, how do you diagnose, how to manage them medically and surgically. Hope now a lot of you people out there are able to understand what fibroids are and that they can be managed. And despite having fibroids and despite having severe symptoms from those fibroids, you can still overcome infertility and have a baby. We hope you join us again next week, and we look forward to bringing you another important topic of discussion related to infertility. Thank you so much.